Welcome everyone to the second webinar of our series Head and Shoulders, Knees and Toes, Neurological Presentations in Serious Mimics, hosted by the Physician Learning Program, the Office of Lifelong Learning, and the Multidisciplinary ALS Clinic. My name is Melanie Hetherington, and I'm an education specialist with the Office of Lifelong Learning and the Physician Learning Program. Our mission here at the Physician Learning Program is to create actionable clinical information by engaging with physicians, teams, partners, and patients to co-create sustainable solutions to advance practice. We are dedicated to moving evidence into practice by fostering a culture and environment where everyone works together to tackle our most pressing problems. We acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. Just before we begin, I just want to go over a few housekeeping items. So please use the chat feature if you have a question about technical difficulties or any questions about our programs and services. If you have questions for our speakers, please use the Q&A feature of the webinar. Please review what has already been asked and upvote those questions you would like to have answered. There may also be an opportunity at the end of our presentation for those who would like to voice their questions aloud. We can't guarantee that we'll be able to get to all of your questions today, but we'll do our very best to try. We will be using Mentimeter for this presentation. So if you would like to participate in the interactive discussions today, you can scan the QR code on the screen or click the link that Westerly will be putting into the chat in a little bit. That QR code will be displayed throughout the presentation as well, so you will have an opportunity if you don't get a chance right now. A recording of the webinar and a Pearls for Practice document with takeaways and resources will be sent via email to all of those that register after the 4 sessions have been completed. This activity has not been formally reviewed by the CFPC or the Royal College. However, it is eligible for non-certified credit. Participants can also claim certified MainPro Plus credits by completing a personal development plan activity using the MyL3 plan, and the QR code for that is on the screen there as well. So with that, we're very pleased today to, I'm very pleased to be introducing Dr. Wendy Johnston, who if you joined us for last week's session, you would have met her already. And as well, Dr. Daniel Falk is here for our session on Numb Hand, Is It Always Carpal Tunnel Syndrome? Dr. Wendy Johnston is a neurologist who is certified to do EMG. She's a professor of medicine in the Division of Neurology at the University of Alberta and the former medical director of the K. Edmonton ALS Clinic. Her research focuses on neuromuscular conditions, including ALS. Dr. Daniel Falk was a practicing neuromuscular specialist in Kelowna for 3.5 years and a clinical assistant professor at the University of British Columbia, Southern Medical Program. He is now an assistant clinical professor at the University of Alberta and a neuromuscular specialist with the neuromuscular group out of the K. Edmonton Clinic. When he's not busy with his 2 young daughters and exploring the bike paths in Edmonton, his interests are in quality improvement initiatives, medical education, and clinical trials. So thank you both so much for being here with us today, and I'm going to turn it over to you guys.
So I'm welcoming you back, or welcoming you for the first time. And today's session is focusing on carpal tunnel syndrome and some mimics. And I'm interested in any thoughts that you have about things or presentations you thought were carpal tunnel syndrome, but turned out not to be. And what was it that it turned out to be when you followed up or investigated? And I encourage everyone to put a notation in or put some words in, because then our word cloud will get bigger and bigger and bigger. Ifazia is saying she still doesn't have any voice. Mel and Wes. So please, Mentimeter is anonymous, and if you could put in any thoughts, alternative diagnoses, and try and populate this a bit more if you could just type in a few words. The things that you're reporting are vascular conditions and neuropathy, as opposed to just a single nerve involved in carpal tunnel syndrome, and MSK conditions or osteoarthritis turned out to be other potential diagnoses. So next slide. So our goals today are to look at the key clinical features for the differential diagnosis of common, uncommon, and rare causes of hand symptoms, with an emphasis on understanding carpal tunnel syndrome and the actions we take around carpal tunnel syndrome, and then to consider alternatives that can present with hand symptoms. We are both, Dr. Falk and I, do EMG, and so we do almost rely on EMG as an extension of the physical exam. So talking about the role of EMG in the diagnosis of carpal tunnel syndrome and other hand symptoms will be a key part of the presentation. And then to talk about how you as primary care physicians, assuming most of you are primary care, or how any of us can get a better consultation request, how we can frame our consultation request to get the best bang for our buck. Next slide. Over to you, Dr. Falk.
Thanks, Wendy. Yeah, so we're just going to start off with a pretty basic case, something that you would often probably come across in your practice. So this is a 35-year-old right-handed female construction worker. She's been complaining of numbness and tingling into her hands. She notices that it'll frequently awaken her at night, or she'll notice it first thing in the morning, and she'll try to shake it out or flick her hand to make it feel better. And it was much more noticeable on the right compared to the left for at least the past year. She has noticed over time that there was some daytime aggravation with recurrence of her symptoms with holding a phone, using a steering wheel, or using power tools. She'll occasionally drop some items with her hands when she notices the numbness and tingling, and they'll just kind of slip out of her hands in that sensation. She denies having any neck pain, any radicular symptoms. She otherwise feels well with normal bowel and bladder and no leg numbness and tingling or weakness or any other significant leg symptoms. Slide. So looking at a focus examination that you might perform in the office. So there's no atrophy of the hand intrinsic muscles when you're looking at the hands. They look pretty nice and plump symmetrically. There's normal tone. Testing her shoulder strength and her proximal arm strength and distal hand strength was normal, including abductor pollicis brevis and opponens. So for those that utilize these tests, so you can either do an okay kind of thumb sign like this, and then just try to get them to try to pull through. And by and large, that should demonstrate pretty, you shouldn't be able to technically do that. And then doing an opponents with either the thumb and the pinky or the thumb and the fourth finger. Testing APB is a little bit more challenging. So I tend to get them to have their palm flat and then bring their thumb up into this abducted position, and then subsequently try to push it down distally. Otherwise, she has normal reflexes to her brachioradialis, biceps, and her knees and her ankles. She does demonstrate some decreased sensation to the thumb and index finger, but this normalizes in the palm. And Tinel's is present at the wrist, and a Phelan's test is positive, and there's no palpable tenderness to her joints, to the wrist or the hand. Next slide. So putting this all together, what would your actions be for this patient that has symptoms that seem suggestive for carpal tunnel? We'll wait for some responses to come in.
So we're really hoping that people will jump in and give their opinion as to what they would do. Could be all of the above, none of the above, although we don't have a none of the above. but all the things that you would do to move along the management of this patient. So we're hoping to see, of our 43 participants, if you've been able to upload Mentimeter and provide some idea of what direction you would take.
So we have some responses for trial of risk and physio.
Now we're getting more people, I think, are getting included into the Mentimeter platform. And okay.
Great, perfect. That's actually really good. Yeah, I mean, should we chat about this slide for a couple of minutes then, Wendy?
Sure. So I think the majority wanted to do a trial of risk in the context of this classic scenario. That's entirely the right choice. Oh, there's someone else coming in with neuropathic pain. Plain X-ray, that's not something I would generally think of unless the respondent was detecting something that suggested osteoarthritis or a concern about arthritis that's directed towards that diagnosis. Physiotherapy is something we might want to chat about, because I personally don't see a role for physiotherapy in carpal tunnel syndrome, and we can debate that. And then one person thought an EMG might be helpful. We do EMG, so of course we think it's helpful. And we don't see patients without our handy EMG machine, so we're obviously very biased. But there definitely is a role for EMG, and Dr. Falk has a very nice decision tree that can help with that. And then again, I think MRI doesn't really seem to have a role here. It's rarely do I do imaging of peripheral nerve when it's a classic case, and then neuropathic pain medications. If a patient's very distressed and having a lot of neuropathic symptoms, I think it's entirely reasonable to consider pain management. What do you think?
Yeah, no, I entirely agree with the distribution of responses. I think, the majority have suggested the trial of risk, which is very appropriate for a very classic case of this. I've seen plain X-rays done, but typically only in the context of some people that tend to have a lot of painful swollen joints, and when it really seems to veer away from the diagnosis of carpal tunnel syndrome, which we'll get into on the next couple of slides. So I think that's great. Why don't we advance to the next one? So rightly so, we'll just jump into some of the things that make us not think about carpal tunnel syndrome. And so some of these things tend to clue us into alternative, much more serious conditions. So number one, if it was like abrupt onset and all of a sudden that they had persistent numbness and tingling in their hand, that would be caution for someone that does not really fulfill what we would expect for carpal tunnel syndrome. If they had progressive symptoms that were, again, not episodic, and progressive weakness on the hand muscles. So weakness is a significant concern, but both in terms of functionality, with being unable to do a lot of things with hand dexterity, as well as it can be concerning that there might be something else that's going on. And another red flag would be consideration of proximal weakness that would be out of keeping of where we would localize the carpal tunnel syndrome to, which would be the median neuropathy at the wrist. So if there's difficulties with putting things up in the high cupboard, or lifting up grocery bags using their biceps, then those would be, again, concerning features. And then worsening functional decline, autonomic symptoms, and constitutional symptoms such as weight loss, orthostatic symptoms, and severe constipations. Those, again, clue us in that there might be an alternative diagnosis that's waiting in the wings.
And even if we still think it's typical carpal tunnel, functional decline, that is weakness developing in the hand, is still an urgent concern, because people can have severe carpal tunnel syndrome, and losing function in the thenar muscles is very disabling. So even if everything else fits with carpal tunnel, or if it emerged from being episodic to being more persistent, then those are still indications for urgent referral because of the functional impact of that maybe single nerve involvement. So even if it's not pointing to a different diagnosis, it's pointing to a carpal tunnel syndrome patient who needs priority assessment. Next slide.
Yeah, so what can cause other hand symptoms? So we can break them down into essentially the neurological and the non-neurologicals, which include a variety of conditions that are musculoskeletal or rheumatologic. So for example, osteoarthritis, rheumatoid arthritis, or other inflammatory arthritis, mechanical wrist pain, or de Quervain's tenosynovitis. And then if we think about other neurological causes, they tend to have different examination findings, and again, more of the red flags would be present. So in general, you could have a stroke that causes hand weakness and numbness. You can have a cervical myelopathy or cervical radiculopathy, a syrinx in the cervical spine. Some patients may complain of hand numbness or weakness, but they may actually have stiffness and presence of a tremor, which may clue us in that they are actually manifesting as Parkinson's disease rather than anything else. And then there's also other rare neuropathies that can fool us sometimes in feeling like that it's carpal tunnel syndrome, but it could be something that's either inflammatory mediated or even hereditary. Next slide. So in terms of when to request an EEG for numb hands, so if the clinical history is very consistent with what you would expect for classic carpal tunnel syndrome, so episodic nocturnal numbness and tingling, I find the flick sign or flick history very, very helpful in those scenarios without the presence of any red flag features. And they have essentially mild and not significantly disabling symptoms. You should consider doing a trial of conservative interventions first with carpal tunnel wrist splints. You might consider ultrasound-guided corticosteroid injections or even some ergonomic supports through occupational therapy. And if their symptoms persist or they deteriorate, again, it's helpful to get nerve conduction studies to demonstrate the presence of a median neuropathy of wrist alongside a history of carpal tunnel syndrome, which then may lead to consideration for surgical decompression. Specifically, if there are red flags that are present, those should immediately be referred for nerve conduction studies. And this slide was actually created out of one of the rural programs in the Interior Health Region, BC, of which I'm part of. And so the availability of EMG might differ between different locations. So if everyone here is generally speaking within the Edmonton zone, the referrals for an EMG might be quite a bit easier perhaps than in other outside locations. And so this is kind of like a guide in general to consider effectively conservative interventions while you're considering nerve conduction studies, or when to consider nerve conduction studies first and foremost, while considering to trial also conservative interventions. So, yeah, sorry, Wendy, did you want to?
Oh, I just wanted to emphasize that in addition to the conservative interventions, you had listed that there were reversible factors. So we often see people with mild carpal tunnel syndrome, but on closer questioning, they have symptoms of early diabetes, for example. It's not uncommon for women who are pregnant to have symptoms of carpal tunnel syndrome, and managing that while they're pregnant, they may never need their conduction studies if they have good results with a splint and they deliver and the symptoms resolve. So depending on the context, the management of the other risk factors could have a positive effect on outcome. Other risk factors really point us towards the potential for more severe disease. So chronic kidney disease, trauma, recurrent repetitive activities of an occupation that continuously brings out the symptoms. If occupational adaptation or ergonomic consultation doesn't assist with that occupational hazard, if you want to call it that, then all of these can be underway without really waiting for the EMG studies, which will give us a sense of how severe the median mononeuropathy is. The other thing that I like to emphasize, which I say to patients all the time, is carpal tunnel syndrome is a clinical diagnosis that a doctor could make without neuroconduction studies. The role of neuroconduction studies is to assess, first of all, confirm the localization, second, to assess the severity. Confirming localization is what the surgeons are looking for. They don't want to operate on a nerve that is compressed elsewhere in the arm, and they don't want to operate on the wrist. So the rare cases where the symptoms are a mimic. So definitely surgeons usually require neuroconduction studies. Even ultrasound is not sufficient currently for most physicians, most surgeons to plan surgery. The localization is very important. We haven't discussed ultrasound, and I think increasingly ultrasound has been made available. Sometimes the ultrasound is helpful in pointing out that the nerve is swollen in the region that you suspect. Sometimes it's not helpful because it may show additional swelling in other nerves that's asymptomatic. So, you know, like a lot of things, ultrasound is a test that's potentially coming into its own, but it's still in the early days of knowing where it sits in the spectrum. I think when we get a referral and the referring doctor has said the ultrasound shows, you know, a swollen nerve, we would prioritize that referral for confirming localization and assessing whether that patient is a priority for moving on to interventions. So I think this is a great guideline that's been developed, but it does ultimately lead to a decision tree based on the patient's symptoms.
Yeah, great, thanks. Thank you. So just to kind of bring the case to conclusion, so this patient trialed carpal tunnel response for 3 months. They didn't really find that it was, well, it maybe helped them a little bit, but they continued to have poor sleep and still some functional impairments, still dropping items. She had nerve conduction studies that demonstrated evidence that there was at least a moderate median neuropathy at the wrist. And because she was still bothered by her symptoms despite conservative therapies, this ultimately ended up to help with a treatment plan to refer her for surgical decompression. So pretty
and it's
classic.
also interesting. Yeah, but it's also interesting, and we didn't really emphasize this point, but she is a construction worker, and it may come up that whether this is a workman's compensation case or not, but certainly the occupation of the patient is a factor in determining whether to move on to more aggressive therapy or to continue with supportive therapy. So being medicated is still miserable. If a patient isn't sleeping, that isn't good. And using medications to manage the sleep while they're under conservative therapy is reasonable. But if you're going 6, 9, 12 months and they're still not sleeping and they're still having functional implications, dropping instruments at work, dropping hammers in a construction site, then the entire holistic approach to the patient might point to the need for intervention. And that's where the neuroconduction studies reassure the surgeon that we're actually operating on the carpal tunnel, rather than it being another cause or another factor that's leading to the overwhelming symptoms. So at this point, we can quickly move on to case 2. So you may detect, those of you who were here last week and this week and coming up, there's a little bit bias in our presentations. So the second case is a 52-year-old woman who has a 6-month history of numbness of her left hand that's been progressive. She, when quizzed a little further about it, she said, it just doesn't feel right when I use it. She doesn't really endorse other sensory symptoms such as pinprick change, feelings of paresthesias or pinprick or pain radiating to her fingers. Her hand just doesn't feel right and doesn't move right. She's found it harder to carry groceries. She's found that she's been getting progressively worse over time, and at the same time, she hasn't really had any other symptoms that she's noticed or brings forward. So she doesn't have the pain or paresthesias. She has no long tract signs into her legs or no normal bowel bladder function. She has no systemic symptoms of weight loss or autonomic symptoms. So still kind of isolated to the left hand symptomatically, but not a little more involved in terms of function than you might expect from a simple mononeuropathy such as carpal tunnel syndrome. Next slide. So when, in your experience, when a patient tells you they have a numb hand, ultimately, what does that turn out to be? What does a numb hand mean? So I hope that you can jump in and give us some other words that might expand on what numb means to your patients. Do they always mean that it has decreased sensation, that it's not sensitive, that they can't feel temperature? So the diagnosis that's being put forward is neuropathy, that patients, when they say numb, they mean they have decreased sensation. Any other thoughts on what other symptoms they might be describing? So you've got cold, so patients might also report their hand is numb and cold. We're really veering more to burning or other sensory symptoms. Lack of strength, that's something that we don't necessarily associate with numbness. At least I didn't associate in my training. Numbness meant sensory symptoms, but loss of strength is one other potential diagnosis. Weakness, decreased function, so more general decreased function. So we're seeing that there's a lot of expanded sensory symptoms that a numb hand could represent, but also that a numb hand may actually represent something that I would regard as primarily sensory. Next slide. So numb really comes down to, does it mean they can't use it or they can't feel it? And when I first started in practice, I really thought numb meant numb. Numb meant decreased sensation. And I had to start asking patients, when you say numb, do you mean that it's not working? And I had people say, well, it's like a block of wood. It doesn't do what I tell it. And so someone with a stroke, for example, might say I have a numb hand, and yet their sensory exam is normal. Whereas others will say numb, and they're quite clear. It's numb, it's tingling, it's burning, and all the other attributes that we ascribe to neuropathic symptoms from the sensory nerve involvement kind of round out the numb symptoms. So when someone says they have a numb hand, it really is important to dig in and say, what do you mean by numb? Is it not use? You can't use it, or you can't feel it? And sometimes that can be a little hard to dig into with some patients. Next slide. So what would this patient require in terms of your next steps in your office or clinic? So a patient who has these more motor symptoms, who's describing functional decline with not really a lot of sensation, you'd really expand your exam to a more complete exam of saying, are the cranial nerves normal? Do they have any symptoms of dysarthria or dysphagia? Do they have any diplopia? Have they developed droopy eyelids? Then you do a more detailed exam of both upper extremities and lower extremities to say, is there any unperceived or weakness that the patient has kind of sloughed off or didn't think anything of? The reflexes are really important. In fact, sometimes when a resident physician is presenting to me, it's like, I can't wait for you to tell me the reflexes, because that tells us so much about the upper motor versus the lower motor neuron. The sensory exam is really important. Now, sensory exam is it's a challenge, and I have to say that I hate the sensory exam. I usually leave it to the end, and I do a very directed sensory exam. So there's a general sensory exam where you're testing for more length-dependent symptoms. So you're testing distal versus proximal, but you also may be driven more by the symptoms. So if someone's complaining of a numb hand, you then compare side to side. Pinprick and light touch the same on both sides. Can they point out any areas of sensory loss? If you go in blind to a sensory exam, one of the truisms in neurology is people with normal sensation are very able to discern subtle differences. And so it's, you do the pinprick and they go, can you do that again? Oh, I'm not sure. Can you do that again? Such that I tend to push people to declare not subtle changes. Is this significantly different? If this side is $1, then how much is this side 50 cents or is it 95 cents? So not being misled and not spending an enormous amount of time trying to pin down subtle sensory symptoms is a key to an efficient neurologic examination. And then coordination and gait. Often when I'm examining patients, particularly in the EMG lab, where I may be seeing someone who's been sent in for carpal tunnel syndrome, I just get them to get up and walk, or if I can, watch them walk into the examining room, and they just test balance and gait in a very quick screen, which tells us a lot about the lower extremities. So certainly if you're able to observe the patient coming into the office or get them to just stand up and walk across the room, you get a better sense of if there's any dysfunction in coordination and gait. And then again, when you've got a numb hand, is the hand slowed? So patients with Parkinson's disease will have slowing. They might have the tremor, which only comes out in certain positions. Upper motor neuron can present with slowing of movements. And on finger, nose, are they accurate? And so is the numb hand something that's going along with more of a posterior brain syndrome, such as the change in cerebellar function? So quickly going over at least finger tapping can really help figure out whether this is a peripheral nerve problem or if it's more central. Next slide. So in our patient's case, she had pretty normal head and neck appearance. And again, with a patient who, particularly if they're known to you and there's been no change in their facial features, they don't appear to have a facial droop, there's no droopy eyelids, their speech and swallowing, their speech is normal, they haven't reported any swallowing deficits, you may not end up doing a detailed cranial nerve exam, but you're thinking about it. But when you're examining the limbs, just picking up and moving the arm, the involved arm, and it should be left arm, sorry, it just seems a bit stiffer and actually has a bit of spasticity. So brisk movement tends to have that clasp knife component. And looking at the hand, it has what we call in neurology the split hand. So in addition to flattening of the thenar surface, there's a scooping out of the first dorsal interosseous. So in this diagram, in this illustration, you can see that the thenar eminence has been entirely flattened. It's a straight line rather than being a plump little muscle there. And then flipping the hand over, you see wasting here. In our 52-year-old woman, this would be a red flag. Now, it's often difficult. If she was 82 and she had arthritis, seeing a bit of scooping out of that region can be a bit difficult to figure out, because as you know, as elders get older, the subcutaneous tissue gets less, the joints and tendons tend to be more prominent. And so you can look at a hand and think, wow, do they have atrophy or are they just old? So in this case, with a younger patient, it seems quite clear that there's atrophy of both the first dorsal interosseous and the abductor pollicis brevis. And that hand is very typical in that she probably can't lift the thumb up 90 degrees perpendicular to the palm. You also note that there's muscle twitching or fasciculations, not just here, but in the upper arm and in other parts of the body. Now, muscle twitching, it can be very common, and fasciculations alone don't necessarily promote that there's a primary neuromuscular diagnosis. But in the context of weakness, fasciculations are very concerning. Interestingly, patients who have benign fasciculations are often really bothered by them. In fact, they're driven a bit crazy. And it's not been unusual for me to get a call from a family doctor saying, I have a patient who has fasciculations and they're really, really worried that they have ALS. And I'm like, yes, I respect that. But if they're not weak, then I'm not as worried. So fasciculations alone, particularly if they're very bothersome, can be normal. Someone who's just run a marathon will fasciculate all over. So fasciculations in the right context are a bit of a red flag. We also note that her reflexes, remember how much I love reflexes? The reflexes are brisker than you'd expect, but normalizing in the legs. So really brisk in the arm region, which is a bit unusual. If you had a stroke, you'd be brisk in the arm and leg on the opposite side. If you have a cervical spondylosis, if you've got a disc or arthritis pressing on the spinal cord in the cervical region, then the reflexes should be increased everywhere below. So finding of an isolated increased reflexes in the arm with weakness and fasciculations is very concerning for ALS. And she has a normal sensory exam. And so looking at the findings, The weakness extends outside of the hand. It extends into the forearm muscles of the flexors of the fingers and the extensors of the fingers, and there's even weakness of the deltoid. And then within the hand, reflecting this split hand, the first dorsal interosseous and the APB are weaker than the adductor digiti minimi. So the muscle under the pinky is more rounded than the other muscles. And that is very interesting, of course, because it's the same nerve. So the FDI is on the ulnar nerve, and the adductor digiti minimi is from the ulnar nerve. And so that is one of the reasons that this is considered a cardinal sign of ALS. It's felt to probably represent the cortical motor representation rather than it being strictly from the peripheral. I'm getting very deeply into neurology here, so apologies if you're getting a bit bored. Next slide. So just to remind you, those who were with us last week, that within the motor system, us neurologists love to talk about upper and lower motor neurons, and that's because that's how we're organized. So as I say to patients, the brain is the executive level, and the spinal cord is where the workers are, and the workers then go out and do the work by telling the muscles what to do. So upper motor neurons are where the programs are created, and then they transmit it down to the brainstem for the face, tongue, and throat muscles, and then further down into the arm and leg muscles. So the upper motor neurons, if they're affected, tend to lead to increased tone or spasticity, brisk reflexes, and the emergence of primitive reflexes, of which the Babinski sign is the best known. Lower motor neuron findings include atrophy or wasting, decreased tone, and reduced or normal reflexes, and fasciculations. Fasciculations are a sign of an irritated motor unit. So fasciculations don't occur in primary muscle disease, but they can occur in anything that annoys a motor neuron. Particularly, it's a sign of metabolic stress. So in disorders that affect motor neurons and degeneratively, that the function of the metabolism in supporting all these long axons is probably the reason for the fasciculations. And someone who's just run a marathon, they're just generally depleted, and that is the explanation for their prominent fasciculations, which will improve with hydration and nutrition. Next slide. So red flags to consider. I'm going to reemphasize Dr. Fox, Daniel's point of sudden onset. So sudden, in general, sudden is stroke or trauma, really. And so nerves can have strokes too. So sudden onset of hand weakness, if it's generalized numb hand, it could be a stroke. If it's in a single nerve territory, then it could be a nerve infarction. And if there's rash and systemic symptoms, then you may be dealing with vasculitis. And that is, in fact, an urgent concern. Another red flag is weakness outside of the hand that's the subject of the complaint. So in our patient, they had weakness of the forearm muscles and also proximal muscles. If we're thinking a weak hand is a sign of cervical spondylosis or cervical disease, then bowel or bladder symptoms from long tract signs, radicular pain, these would point to maybe being the spinal cord or the spinal cord and nerve root. And then speech and swallowing changes, again, something outside of the one hand. Always remember that we tend to hold fast to Occam's razor, trying to find one diagnosis for all symptoms, but have to keep at the back of my mind Hickham's dictum that patients can have as many diagnoses as they feel like. So a patient can present with classic carpal tunnel symptoms, and that's why they're seeing you, because they're waking up at night. But you notice they have atrophy of the first dorsal interosseous. You notice that their gait has actually changed. And even though they're there for their symptoms of carpal tunnel, your spidey sensors are saying, hey, I think there's something else going on. And that is something to pay attention to. Patients will come in with what's bothering them, and they may not be that bothered by their gait change. They may not be that bothered by some of the other symptoms that you're observing, especially if you're their family doctor and you've known them for some time. Next slide. So what would you do next? Please use Mentimeter, because that's one of the things that I've really looked forward to in presenting these talks, is the opportunity to do a little more interaction. So you have some choices here. Would you send an urgent EMG request? Would you order an MRI of the brain? Would you order an MRI of the spinal cord? Would you do some routine lab testing? Would you do it stepwise, or would you do it all at once? And so you can choose as many answers as you want. We're not asking you to do a rank order because I didn't really know how to do that on Mentimeter. So there's really many people are logging in. Thank you so much. I think we're kind of setting a record for this presentation and the number of participants. Great. So we got 5 more seconds, and I'm going to wait a couple of seconds because I think after the last poll, a few more results came in. So we're just going to wait a little bit, and we see that we clearly have convinced you that EMG might have a role here, and MRI, you know, given the hyperreflexia, not a bad choice. MRI the spinal cord, also not a bad choice, and I'll come back to that. And then routine lab testing, absolutely. When I talk to students and residents, I say it's never wrong to do a B12. It's never wrong to do a TSH because B12 can be normal 2 years ago and not normal now. So B12 can always be a confounding factor, even if there's an alternative diagnosis. And then creatine kinase I threw in there because creatine kinase, people will do that as a response to, well, I have a weak patient, so I'm going to do CK. And I think it's, I find it helpful, but it can be diverting. So someone who looks like they have weakness, hyperreflexia, and they've elevated CK, many clinicians will think, oh, CK, it must be a muscle disorder. Maybe it's hickam-dickum and they have 2 things. They've got a muscle disorder and they've got something in the central nervous system. And so I'm going to send them to a rheumatologist. Well, you know, the EMG can help sort that out. We can sort out muscle from nerve. So don't worry about getting another specialist involved. If all your test results show an elevated creatine kinase, that will be factored into your EMG referral. Next slide.
Well, I was just going to say something about the CK.
Yeah,
just
go back.
If you're okay with that. Just
Sure.
I highly value the presence of a CK even before the nerve conduction studies are done, or just if it's ordered, especially if someone's weak, because you know, a very elevated CK can be very helpful in certain situations. A normal CK may not tell you that much, but a very elevated one would be helpful. And then conditions like ALS can also have an elevated CK as well too. So not, again, as Dr. Johnston said, not necessarily just the myopathy can present with elevated CK.
Yeah, so we find CK very helpful. Next slide. So I think a tip-off that something's going on is the length of the report. So I'm going to romp through this. So a typical EMG report will have a clinical summary because the EMG physician takes a history and examines the patient. So they'll have a clinical summary. Then they'll report on the nerve conduction studies. They'll report on the EMG. They'll usually indicate a test, what's the result of the test, and then a final diagnosis. In this case, there were findings. First of all, the clinician doing the testing confirmed your findings that motor, no sensory, nerve conduction studies showed no abnormality in the sensory nerves. The motor nerves were fine, but there was no conduction. The motor nerves were low amplitude in the affected limb, but otherwise normal. The EMG showed acute and chronic denervation in the weak muscles, but also in muscles that weren't weak. And so a suspicious EMGer will jump outside of the territory that appears to be involved to see if there's any subclinical involvement. So the test report said the technical response is this is a motor neuronopathy, but in the clinical context, this is very typical of ALS, and a recommendation to refer to the multidisciplinary clinic was made. So next. So in this case, the MRI appointments were still pending. The EMG happened to have happened first, likely because all the red flags were identified in the referral, and a consultation was obtained after referral to the ALS with a neurologist who specializes in ALS, confirming the diagnosis. However, they were able to expedite the MRI to make sure there was no potential confounding diagnosis. With symptoms and signs only below the neck, even though it was very suspicious for ALS, you'll have to rule out cervical spondylosis or cervical myelopathy. It's not wrong to do an MRI of the brain, and compared to 20 years ago, I routinely order MRI of the brain because there are occasional surprises, and it's become an expectation that you're not approaching this diagnosis seriously unless you've done the appropriate imaging. So in this case, the patient was enrolled in the multidisciplinary clinic, and the currently Health Canada approved therapies were initiated because she was referred in a timely fashion. The therapies are time linked, and so without a timely referral, we can't initiate therapies at times. Next. So what will a consult get you? Well, you hope it's going to get you an answer. Certainly you're looking for direction for future management, and some consult forms have a tick off, please make suggestions. Some say take over care. So when you're making a referral, and this applies more to our first case than our second case, discuss with the patients to see if the referral is going to meet their needs. So if the patient said there's no way I'm going to have surgery, then you're not going to bother referring them to a surgeon. They may change their mind down the road. But it's important before you make the referral to ensure the patient understands what the referral involves and what the decision they may have to make based on it. And at this point, you may have to share your concerns about a potential diagnosis. And the concern may be, I think it's carpal tunnel syndrome because I've seen it before and I'm pretty sure that's what it is. Or it may be, your hand isn't working properly. I've had a few patients with that, and it's neurological, and I'm concerned it might be a serious diagnosis that we need to get to the bottom of. So it doesn't have to be into chapter and verse, no data dump required, but orientation to say, hey, I think like there might be a serious diagnosis, in which might help them keep the appointment, for example, as compared to, oh, I just had a little bit of a numb hand. I've got other things that I need to do. Next slide. This, I think, we'll just include in the presentation. We presented it last week. I alluded to the nerve conductions, which is the part with the electrodes you can see in the simulator, and then the needle EMG. So it's a two-part test. Just to emphasize, it's done by CPSA accredited physicians who've done special training in EMG, and it's only done in approved labs in Alberta. Next slide. This is just reiterating that point. Next point. So how long, when you refer someone for EMG, how long are your patient waiting? If it's just routine, if you haven't asked for it to be urgent or expedited. So what's the reality? Where are we in trying to get people in for what we certainly feel like is an important test? I'm seeing all over, and I suspect that the 12 is people are going, are you kidding, 12 or more, 12 months. So we can see that so far we've had responders indicating anything from very prompt EMG appointments to a little more distant, and then 3 out there at the 12 months or more end of things. So that's quite a spectrum of responses, and I do wonder if it reflects the immediate. So if this is a routine that gets done within 3 months, that makes me very happy, because that would be our goal. We try to see routines between 3 and 6 months. So someone who's having sensory symptoms is referred for a carpal tunnel assessment. We'd see them in 3 to 6 months. Someone who has progressive weakness, we would definitely want to see between 6 and 12 weeks. And if this was deemed to be urgent, seeing them within 4 weeks. If they have multiple system involvement, then that would be urgent and might need a phone call. Next slide. So to get a good result, you have to give the right information. If you say rule out carpal tunnel syndrome, patient will be booked for a half hour. It'll be a very focused exam, and it'll be focused on ruling it in or ruling it out. But if you say, well, symptoms of carpal tunnel, but progressive weakness, functional decline, even that additional information will push the patient up the priority list. Once you start getting into real red flags, then you're moving the patient closer and closer to having a very timely appointment. Next slide. So while you're waiting for your consult, whether it's with a neurologist or an EMGer, you continue to manage system. If a patient is weak, reassess them for progression. And you may have to contact or resubmit the consultation if you feel that the timeliness of the referral is not appropriate. Consider other pathways. Next slide. So another problem that we've heard about from primary care is that you send the patient for the EMG and the EMG comes back as normal, or you send the patient for an MRI and it's come back as normal, or the specialist that you refer them to says, oh, it's mechanical back pain, and they don't address the question. So that's a big challenge, and I can't answer that right now, but the second opinion within the specialty, trying to get an EMG from another specialist if that's the problem, the EMG didn't give you the answer, reframe the consultation request or send it back to the consultant and say, but you didn't answer my question, or call someone. And so the call someone option meant I have, when I've been on call, received rapid calls for advice. There's Connect MD, which you saw in the rotating slides at the beginning. And honestly, if you think it's ALS, the ALS physicians would be happy to respond to your concern. So I have one more survey, which can be done while we're doing questions. I always wonder when we do an EMG test, are we just doing a test and then we give the result back and it's totally back to the family doctor or the referring doctor? Or when we do a test and we see something concerning, like someone who's got a severe carpal tunnel, for example, or that we think they have a vasculitis, or we think it's ALS, should we then expedite that referral, letting, of course, the referring doctor know that, hey, we think it's this, and we've taken the liberty of moving it on? So I'm just interested in how many of you feel that scenario 1 is your preferred scenario or scenario 2. And when you respond, it puts a dot on which scenario you like. So Mel, over to you.
Thank you so much, Dr. Johnston and Dr. Falk, for the excellent presentation. If you have any questions for our speakers, please, you can start putting them in the chat or in the Q&A. Or if you'd like to raise your hand and ask your question aloud, you can do so as well. Just before we get to those questions, I just have a few quick slides that I would like to go over. So I just wanted to take a few quick moments just for you to reflect on what you've learned today and think about how you might be able to incorporate that learning into your own practice. So studies have shown that when we're thinking about making change, we're more likely to implement those changes when we write them down. The Office of Lifelong Learning has developed a platform called the MyL3 Plan, which the QR code is there. It's a free online tool that will allow you to meet and support the 3 activities or action plans required by the Physician Practice Improvement Program of the CPSA. And you can get quite a few credits for doing these exercises. So 24 credits for the practice-driven quality improvement activity, 6 for the personal development plan, and 6 for the standards of practice quality improvement activity. Physicians can delegate support staff to assist them, and you can do it as many times as you'd like. You can also earn credits if you're a CFPC member by completing a linking learning to practice exercise. It's a self-administered, semi-structured reflection exercise. And you can earn 5 certified Main Pro Plus credits. And I'll put all of the links in the chat as well after I've finished. We really value your feedback as it helps us to improve the quality of our educational programs. It also allows us to ensure that we're meeting your needs, and it shouldn't take more than 5 minutes. As a thank you, you'll have the opportunity to participate in a raffle for a $10 Starbucks gift card, and that raffle will close in 2 weeks. And then finally, I just wanted to take a few minutes to let you know that the Physician Learning Program is hosting a PLP Summit on advancing practice through the power of partnership. It will be held here in Edmonton on June 11th, and our keynote speaker is Dr. Victor Montori from the Mayo Clinic. So we're really looking forward to seeing you all there. And with that, I'm going to open it up for questions. And I do see we have one in the Q&A here. I
can answer that live. Yeah, it's a comment. So the comment is there's a new referral pathway coming for CPS in Alberta. As an EMGer, a neurologist, I'm not aware of this. I'm quite curious as to under whose auspices this is being done. Yeah, someone's asking for the link to the survey again. So Mary, are you still on? Do you want to go live and just give us I see you've raised your hand. Mel, does she have to be unmuted?
You should be allowed to talk now.
Perfect. Can you hear me?
Yep.
Excellent. Yeah, no, I'm actually on that referral pathway group. So with the Alberta Referral Hub, you'll see that there's been more and more pathways that have been developed, and the CTS pathways have pretty well completed it to the point where it might be presented soon and be available to all clinicians. So it's going through, actually I was following the things we were talking about, Wendy and Daniel, and just following to make sure that it was congruent with what we've been talking about in the pathway, and it is. So this is great news that as clinicians, we're going to be able to step by step through, define what's more urgent, what's not as urgent, what kinds of steps should we be taking if we can't get that EMG right away, what can we do? And just if I can speak a little bit to that, the EMG process was a big argument in the group. I can release that information because to EMG or not to EMG is always the question. But it's the length of time. I was one of the people who said 12 months. I mean, unless you say urgent, it's not getting done quickly. And that just delays care. So a lot of the neurologists and plastic surgeons did go back and say, you know what, I get it, and I'm not going to make that hold up your referral. So that's kind of nice for us as primary care clinicians to be able to have more direction as to what to do with carpal tunnel.
Great. Well, I'm not sure who the neurologists were on the process, but I find it very reassuring that being oblivious to it, that our presentation is consistent with your recommendations. I feel like that's a nice fail-safe.
I took a couple of pictures just to make sure, and I'll check it again. And when we meet with our group, I'll let them know I was in on this conversation and just make sure our pathways. But no, we had some pretty smart people, and we had neurologists and plastic surgeons as part of the group, plus primary care. And we also have patients who are part of it as well. So then we know that we're getting all perspectives. So
great. That sounds like to me. And it sounds like something like when Daniel's only been with us for 2 months from BC, it sounds like it's similar to what they were coming up with in the interior BC. Yeah. So in the last minute, Dr. Ryan has brought up that an 11-year-old patient recently diagnosed with carpal tunnel syndrome, and it changed his view on screening, or at least considering the diagnosis in this age group. So that's very interesting. So I agree with you. It's unusual in that age group. And it gets back to, if the symptoms sound like what it is. But the differential diagnosis in an 11-year-old to me would be quite different. So an 11-year-old compared to a 60-year-old is quite a different animal. And when, like everything in that age group, if there's nothing to do with their physique or trauma or anything else, I would wonder more about predisposition, genetic predisposition. There's a condition called hereditary neuropathy with tendency to pressure palsies, and that would be one way that a child would present, would be with carpal tunnel syndrome. So it's a very interesting question, and I would say if you have a 11-year-old with carpal tunnel syndrome, I'd actually seek specialty consultation. If you did a routine EMG and that's what you found, then a pediatric neurologist might need to weigh in. So Peggy Borger said, ever actually seen amyloidosis with bilateral carpal tunnel syndrome? Yes, it is one of the touted presentations. As you know, there's a number of therapies that have been developed for hereditary amyloidosis, and there's been a considerable push to educate everyone about that. So that might have increased our referrals a bit. So yes, it is a potential presentation. And in fact, when I have sent people to surgery, I've asked them to send pathology from the surgery, from the flexor retinaculum, to see if there's amyloid there. There's other ways to detect amyloid, and now there's genetic testing for at least the TTR variant. Daniel, do you have other comments on how many patients with bilateral CTS have had amyloid in your practice?
I've had 2. So it's rare, but it happens.
Yeah, and were they hereditary or were they acquired?
No, so both of them were wild type. for the ones that had CTS. So they were actually seen in the cardiac clinic first, and then subsequently had developed other symptoms. And then I had one hereditary TTR that presented with a painful length-dependent polyneuropathy.
Mm-hmm.
They're
Amyloid is a multi-system diagnosis, but it does have a predilection for the amyloid itself building up in the flexor retinaculum and giving rise to carpal tunnel. So that is a zebra, and occasionally those hoofbeats are zebras.
Yeah, I tend to. So for those ones, I am more geared towards like the very elderly patient that has new onset bilateral carpal tunnel that doesn't do a lot of work with their hands anymore. And also subsequently may have some cardiac features. So that would be the ones that I would be very strongly suspicious for, and would always get like an SPEP and UPEP and a serum free light chains as in addition to routine screening.
And very inexpensive tests that come back right away. So serum light chains, SPEP, if any doubt, that is a really good screen for myeloma too. All right. Well, great.
Thank you both
today.
so much for such a great presentation, and we're looking forward to seeing everyone next week for our session, The Senior with Functional Decline, Geriatrics or Neurology. So thank you, everyone.
Bye-bye.
Bye.